Good evening to one and all, and a very, very warm welcome to episode 14 of Secrets of Neurology, a knowledge feast for all the neurologists. I'm Dr. Manoj Kumar, Senior Vice President of Intas Pharmaceutical, and it's my honor and privilege to welcome all of you this evening. Before I get started, I have a very important quote to welcome our two co-chairpersons, sir. Guru Brahma, Guru Vishnu, Guru Deva, Maheshwara, Guru Sakchat Param Brahma, Tasme Shri Guruve Namah. Ladies and gentlemen, today's episode is a special episode for all of us, and we celebrate together Teachers' Day in advance with a small quote dedicated to Honorable Professor Dr. Sudhir Shah sir and Professor Lakshmi Narasimhan sir. Sir, you have always been an excellent educator who knows exactly how to illuminate a soul with its own light, and wishing both of you a very, very happy Teachers' Day well in advance, sir. The webinar, ladies and gentlemen, is an exemplary illustration of imparting teachings to the neurology fraternity. Let me take this opportunity on your behalf to thank both our teachers, the course directors, Honorable Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir, for the entire journey of more than a year of imparting teachings and learnings to all of us and doing it in the personal capacity for many, many, many decades. Ladies and gentlemen, all of us know Dr. Lakshmi Narasimhan, but as we know, we also have a couple of young scholars today. For them, Dr. Lakshmi Narasimhan is Director and Professor Institute of Neurology at prestigious Madras Medical College. You'll be happy to know that this is the place from where he started his academic neurology journey, and he is heading it today. Sir is recipient of various awards, to mention a few: Paltussi Advisor from AN, A.B. Baker's Award, Best Paper Award at American Academy of Neurology. He has been into executive committee of various international bodies. Immense contribution to the field of neurology, especially in India. Our another co-chair is equally honorable, Professor Dr. Sudhir Shah sir, Professor and Head of Department of NHL MMC and SBPI MSR Ahmedabad. Sir is Director of Neuroscience at Sterling Hospital, Ahmedabad. Writer of 6 books already. Conferred because of his contribution to humanity at large, patients, and contribution to neurology, he has been conferred with most prestigious award by Government of India, Padam Shri. Sir is also recipient of prestigious B.C. Roy Award in the year 2018, recipient of various awards including UNO Award. Various interests such as stroke, neurodegenerative disease, and epilepsy. Ladies and gentlemen, I feel extremely happy to announce that as a token of appreciation, Honorable Professor Dr. Sudhir Shah has agreed to impart his knowledge through his book, Brain and Neurological Disorder, the front copy and the back copy photograph, you see it yourself. It is a simplified health education guide, and he has agreed to give a copy of the same to all the attendees present today. This book has been written with a noble and benevolent cause, and the authors, Professor Dr. Sudhir Shah sir and Dr. Haley Shah ma'am, wish to strengthen the scholarship imbued with a spirit of compassion and life. This will serve the purpose of authors to help humanity by saving lives and preventive mortality and morbidities. May I now invite Dr. Lakshmi Narasimhan sir to speak a few words.
Good evening, everybody, and I welcome every one of you to this series of Neurological Secrets. At this outset, I would like to congratulate Professor Sudhir Shah on writing this beautiful book. I possess a copy already, and the book is a beautiful illustration of neurology being made very simple. Professor Sudhir Shah, with his wide, vast experience in the field of neurology, has given a very simplified concept of neurology to all categories of people, starting from house surgeons, neurology residents, junior residents, seniors, everybody. Everybody can enjoy the book. And in Heli, Professor Sudhir Shah's daughter also has contributed a lot in this book. The illustrations are very good, and I think it's each one of you, it's a worthy possession to have in the armamentarium of neurology book in the neurological library. Once again, I am proud to be associated with great neurologists of the country, Professor Sudhir Shah, and my association. I'm almost he is like my elder brother, and he guides me into every one of my endeavor. I must pronounce to him, sir, and your contributions to the field of Indian neurology is so immense, and I pray the Almighty that we should continue to do this and keep all of us educated in the field of neurology. And your kind gesture of donating this book to all the participants of neurology, neurological secrets is it's a boon to every one of the students. Thank you so much.
Thank you very much. Thank you very much, Dr. Lakshmi. Thank you, Dr. Manoj, for those kind words. Thank you, Dr. Lakshmi, for the wonderful introduction of the book, along with Dr. Manoj. And I wish to welcome you all. I wish to convey the best regards for the Teachers' Day. Happy Teachers' Day in advance. As you know, 5th September is being celebrated to commemorate the birthday of the great celebrity, a great diplomat, our past president, Sarvapalli Radhakrishnan was a great educator. And in his wonderful fond memories, this day is celebrated. And we thought, what could be a better time than this to impart knowledge and educate people with more and more books and information. And that is why this idea of giving this book as a token of love and appreciation to all the attendees who are here today. I want to tell you that Dr. B.S. Singhal, none other than the giant personality of neurology, has written the foreword, and he has inspired me to write the book. It was initially in Gujarati, then I made it in English, Hindi. More than 70,000 copies have been sold, and all the money have gone for the benevolent cause, noble cause, either for the scholarship, education of poor and less privileged, or for the widows of the martyrs of our Indian army and such other benevolent causes. So me and my daughter Heli, we both feel quite contented and satisfied that the book has served multiple purposes. On one hand, it has educated people, and on the other hand, the royalty has gone to the people who really need the money. And to tell you in one line, this book is for one and all. This book was primarily written keeping patient and the relatives and the caregivers in mind. So it is written in a very simplified language without much of the medical jargon, although we have given index as well as word vocabulary, etc. at the end, and also given website addresses in the book. However, the book is also found to be very useful for all types of medical students, may it be postgraduate MD medicine student or neurology DNB student. And most of all, the physicians and general practitioners have taken it as textbook, because This gives the ready reference to all the diseases of neurology and the symptoms and the treatment, which is in the latest format. And also for us neurologists, it will serve the purpose of counseling. If we give the chapters to the patients and relatives, it will serve the counseling, will save over time. So Dr. Singhal, Dr. Kaplan, Dr. Brown, a lot of the people abroad also have appreciated this book because it is one of its kind. So my request is that have this book, go through this and use it at your best and allow us to serve you and humanity in the larger context. Now, this is my request to all of you. You have been the most ardent audience. You have been there from day one until date. For this 14th episode, all of you have remained present from the beginning till end. More than 300 to 400 people every time join. That is the real achievement of this program. I can't thank enough my colleague and my very good friend Dr. Lakshmi Narsingh for giving a lot of shaping and colors to this program, and we both together have worked very hard to bring this format so that all of us can learn, particularly the students and those who are fresh graduates. I want to thank INTAS Global Cell Division led by Mr. Chadda and Dr. Haley and Dr. Manoj and the whole team for kind of wonderful spread of this information, for the infrastructure, for the kind of right time messages, so that the whole conference is being attended by a large number of people. Now, with this, I would like to come back to today's session. May I have the slides, please? As you know, today's presentation, 14th episode, is from the Kottayam Government Medical College, and the case will be presented by Dr. Ajay Radhakrishnan. May I have the second slide? Dr. Kaushik, resident from Madras Medical College, Chennai. It is a matter of good fortune that Dr. Lakshmi is always there to help out. There was some breathing issue for this episode, and we had to change the venue for at the last moment, and therefore Dr. Lakshmi has provided Dr. Kaushik to give the localization of the case. And third, again, Dr. Jacob George, Professor and Head of Neurology, Government Medical College, Kottayam, a very dynamic personality, as we know, who would be dissecting the case, and he will give the review and update of the whole case. So, as we know, Dr. Jacob is trained at JIPMER Pondicherry, where he got his MD degree, and then he was with Suchitra in the Medical College, Thiruvananthapuram, that is for his BM neurology. He mentioned that is personally interested, his professional interests are neuro-ophthalmology, neuropathology, cognitive neurology, and CPC discussion. And we have heard him at several conferences. So I'm sure we'll all will relish the case, chopping up the case and discussion with his great personality. Next slide, please. Dr. Lakshmi has just updated me that the next turn will be from Lucknow. Dr. Ravindra Garg will be presenting a case, and that will be the last Friday of September. I think it is falling on 25th of September. And so we look forward for the 15th episode from Lucknow. With this, I want to once again welcome all of you, congratulate all, and thank particularly Dr. Jacob, George, and the team for taking up today's episode at a very, very short notice. Thank you very much. Thank you. May I request Dr. George to take over?
Thank you, sir. Thank you very much. First of all, I congratulate Dr. Sudhir Shah, sir, for his new book, for his great endeavor. I also thank Dr. Lakshmi Narasimhan for giving us this opportunity. I also congratulate Dr. Sudhir Shah and Dr. Lakshmi Narasimhan for this Neurology Secrets program. And now, since this case was decided in about 5 days, it is not a very exotic case or anything like that. It is a teaching case for the neurology residents. Okay, I think Kaushik is here. Okay. Kaushik, can you unmute and show your, switch on your video if possible? Yeah.
Yes, sir. Yes, sir.
Yeah, Kaushik, I think you have already seen the case, no? You have already gone through the case, I think. Ajay will present the history.
Yes,
Okay.
sir. Yes, sir.
And you can do the analysis. And then Ajay will present the findings. Then you can tell your localization. And after that only I'll intervene. Okay.
Okay, sir. Okay, sir.
Okay. So Ajay, can you start sharing screen?
Okay, sir. Good evening, all. I'm presenting a case of bilateral lower limb weakness. This is a case of 63-year-old gentleman from Alappuzha, Kerala. He's an artist, he's a drama artist, and the patient was first seen by us in January 2021. His presenting complaints were weakness of both lower limbs of 1 month duration. Actually, the symptoms started as pain in both lumbar region, which he described it as dull aching type of pain over both loin, buttocks, and posterior thigh bilateral. And you also notice there is nocturnal worsening of pain, and the pain is present on standing, sitting, and also on lying down position. There is no worsening of pain on cuffing or straining. There is no shooting type of pain radiating down the lower limbs, no allodynia, no sensory loss over the perineal region. Along with this pain, he noticed difficulty in climbing stairs. He had difficulty both in lifting one limb off the ground as well as in balancing the weight on the other limb while doing so. So hence he needed to support himself on the side rails. He also had difficulty in wearing undergarments standing on either leg. And there is difficulty in squatting as well as getting up from squatting position. And according to him, the weakness present equally in both lower limbs and weakness remains static. And there is no history of buckling of knees while walking, no difficulty in wearing footwears or accidental slippage of footwear with or without knowledge, no history of an inversion of foot while walking. There is no history of dragging of lower limbs while walking, no history of an easy tripping over objects, no history of any wasting of fasciculations noted. There is no history of any numbness or sensory complaints of lower limbs except the dull aching pain. There is no electric shock-like sensation or flexing or extending the neck. There is no band-like sensation over the chest or abdomen. No history suggestive of bladder dysfunction, no history of any erectile dysfunction, no history suggestive of bowel dysfunction. Then there is no history of upper limb symptoms or cranial nerve symptoms, no history of any preceding trauma, no history of any fever or chronic cough, no history of any significant weight loss. Regarding the past history, patient was detected to have diabetes mellitus 3 years back, and he is on oral hypoglycemic agents. And currently, the diabetes status is poorly controlled. And he is also detected to have hypertension for 3 years, and he is on amlodipine 5 mg once daily, and hypertension status is well controlled. No history of any tuberculosis, coronary artery disease, chronic kidney disease, or stroke. Personal history and family history, there is no addictions. He is taking non-vegetarian diet, no significant family history.
Kaushik. Kaushik, you want to see the slides again? You want Ajay to keep the slide?
Sir, I have my own presentation, sir. Can I put that?
Oh, okay. You can share about these complaints, is it?
Yes, sir. Only history, sir.
Okay. Very good. We show that. Ajay, you have to stop screen sharing then.
So is my slide visible, sir?
No.
I would like to start by thanking my professor, Dr. Lakshmi Narasimhan, sir, for giving me this opportunity to localize the case. I would like to thank all my professors and faculty members of MIN for helping with the presentation. I would like to thank the organizers of Neurology Secrets for giving this opportunity to me. Now, the first symptom the patient has was a pain in the lumbar, gluteal, and posterior thigh region. There are many causes of this location of pain. It could be neurogenic, mechanical, non-mechanical spine disorders, referred visceral pain, or miscellaneous pain. These are the various causes in all those categories. Now, given that the pain was not aggravated on movement and it did not relieve on rest, it makes mechanical pain less likely. The pain had no radicular radiation. It was not a radicular pain. It was not aggravated on coughing or sneezing. It makes radiculopathy less likely. Symptoms did not improve with rest or forward bending. Makes spinal canal stenosis less likely. Possibly one localization could be a non-mechanical spine disorders. There were two red flags for the back pain in the history. One was the nocturnal worsening of pain, plus the patient being more than 50 years. So etiology, possibly it's an inflammatory or a malignant pain. The next symptom he had was difficulty in climbing stairs. He was saying that he had difficulty in lifting one limb off the ground and difficulty in balancing his weight on the other limb. This suggests impaired hip stability. That could be because of a neurological or non-neurological causes. Neurological, possibly it's because of a hip abduction weakness. The next symptom was difficulty in wearing undergarments and standing on either leg. This could be due to a hip abduction weakness, a hip flexion weakness, or a knee flexion weakness. The next symptom that he said was difficulty in squatting and getting up from squatting position. Now, this could be because of hip extensor weakness, a knee extensor weakness, or a truncal weakness. Now, summarizing, the 63-year-old male presenting with a subacute neurological illness with initial complaint of lumbar, gluteal, and posterior thigh pain, which is followed by weakness of both lower limbs. The weakness is symmetric and proximal. There is no involvement of sensory, autonomic, cranial nerves, higher mental functions, ball bladder, or upper limb involvement. The muscles which are most likely involved is the bilateral hip abductors, bilateral hip extensors, mild weakness of hip flexor, and mild weakness of knee flexors. The structural localization at this point I would like to give is possibly a muscle is the more likely diagnosis. Plexopathy, neuromuscular junction, anterior-dorsal, and radiculopathy. Muscle is the most likely localization here because it is a symmetric onset weakness. It is proximal and there is no sensory involvement. In the history, there is no point against a muscle localization. Regarding a plexopathy, it is a proximal weakness, but it is bilateral at onset, making plexopathy less likely. Lumbosacral trunk involvement might cause a hip abduction, extension, knee flexion weakness, but this will not explain the hip flexion and knee extension weakness. At the same time, there is no involvement of plantar flexion or dorsiflexion. And there is no sensory involvement which goes against a plexopathy. Third differential, neuromuscular junction, there is no sensory involvement, and given the age of 65 years, Lambert-Eaton myasthenic syndrome is one possibility, but there is no autonomic symptoms and the weakness is static. It is not fluctuating, which goes against the neuromuscular junction. The fourth differential I would consider as anterior horn cell, because there was no sensory involvement. It is a pure motor syndrome, but points against anterior horn cell, there is no wasting, no fasciculations, the symmetrical weakness. The last possibility, which is least likely, is a radiculopathy. The points against the radiculopathy is that there was no radicular pain. And given the presentation, if it was an L5S1 radiculopathy, which was causing the hip extension and abduction weakness, there should be some plantar dorsiflexion weakness, which is not there in this patient. So at the end of history, I would like to localize it. The most common differential would be a muscle, sir. And the second most likely etiology is possibly a plexus. And third, I would like to localize the neuromuscular junction.
Okay. Okay, Kaushik. Hello.
Yes, sir.
Yeah, Kaushik, very well done. Can you just take the neuromuscular slide? There is another strong point against that neuromuscular junction. Neuromuscular junction. 4 is no sensory involvement, age, is it? Okay. Against is no autonomic involvement, against LEMS. Okay. Okay. What about the pain? Is pain common in neuromuscular junction disorders?
No, sir.
Yeah, it's very strong point against myasthenia or LEMS also. Pain is not a feature of a neuromuscular junction disorders. Otherwise, all it's very well done. Now we'll see the examination. Then we'll come back. Okay.
Yes, sir. I'll stop slide, sir.
Ajay, screen
Okay,
share,
sir.
guys. Yes. No, we have the videos also. I think Kaushik has not seen the videos. Okay.
Coming to the examination, first we will start with the general examination. Pulse rate vitals. Pulse rate was 78 per minute regular. Blood pressure was 130/80 millimeter mercury in supine position and 120/76 millimeter mercury in standing position after 3 minutes. And there is no other significant general examination findings. Nervous system examination, higher mental function, MMSE was 30 out of 30. Cranial nerves were normal. Motor system, but there is mild wasting of right participles. Tone is normal. Power, upper limbs, normal power bilaterally. Lower limb, first we'll start with hip. There is predominant weakness of hip extension and hip abduction. Hip extension is grade 3 bilaterally. Hip abduction is, there is mild asymmetry. On right side it is grade 2. On left side it is grade 3. Hip adduction is normal. There is mild weakness of hip flexion. It's 4+. So mainly hip extension and hip abduction weakness. Regarding the knee flexion, there is mild asymmetry. It's more weak on right side compared to left. Knee extension, grade 4+ on right, left it is normal. Then angle, dorsiflexion and plantar flexion normal. Then distal muscles like EHL, toe adduction, inversion, evasion, all are formed. Then this is a video.
It will be yeah. The one problem with Zoom videos is that videos will appear broken, so you may not appreciate it very well.
Hip adduction is normal. Then regarding the reflexes, upper limb reflexes, biceps, supinator and triceps were elicited normally. Knee jerk, there is mild asymmetry. Right side it is sluggish, left it is normal. Ankle jerk is elicited normally, 2+. Then superficial reflexes, corneal, conjunctival, abdominal, cremastic and plantar, cremastic were present. Plantar was bilaterally flexor. The video of reflexes. The right side is sluggish, while left side it is normal. Then cerebellar was normal, and gait, it was waddling gait. Sensory, pain, touch and temperature was normal bilaterally. Vibration and position sense was normal bilaterally. Is appreciating pain sensation normally. Sensations of the posterior thigh was also normal. So video of gait. Then skull and spine was normal. SLR was negative, and there was no signs of meningeal irritation.
Kaushik, you want to discuss or your presentation again?
Presentation.
Okay.
Examination. The findings in the examination were this right thigh wasting, which was not there in the history. The lower limb power, the difference in the history and examination was that examination there is somewhat asymmetric weakness. Hip abduction is asymmetric, right more than left. Extension is symmetric weakness. There's weakness of hip flexor, which is minimal, and bilateral mild weakness of knee extensors. The reflexes are all normal except the right knee is sluggish. And in the gait, there's a waddling gait. With the examination findings, the there are 2 points against muscle. One is that it's asymmetric now. The second thing is that right knee reflex is sluggish. But the waddling gait is a point favoring muscle. So even at the end of examination, muscle looks to be the most likely pathology. Plexopathy, it has a bilateral weakness onset. There is no sensory involvement, no distal muscle involvement, and reflex is all present. Neuromuscular junction, the wasting is against neuromuscular junction. The reflex is present is against the neuromuscular junction. And anterior horn cell, given that the quadriceps was having a power of 4+, with wasting, this could be taken in favor of anterior horn cell, given that wasting in the quadriceps was more than the weakness. But on the other hand, there is no mention of any, there's no wasting of the gluteal region. Despite the hip abductors having 2, there is no wasting. That is against anterior horn cell. The reflexes are present against anterior horn cell, and there's no fasciculations. Radiculopathy against, because reflexes are all present, and the weakness is not in the radicular pattern. Sir, can I discuss the etiology, sir?
Okay.
So most likely the structure is muscle, possibly inflammatory or toxic etiology, sir. In the inflammatory, the first diagnosis, most likely it should be an immune-mediated necrotizing myopathy with proximal weakness, acute to subacute onset. The second most likely.
Jacob, sir?
Yeah.
I thought before going into the etiology, let us
discuss.
Make sure whether the structure, I thought we will ensure that we will have your discussion, then make sure what is your thought process, and then go on to the etiology. That will be better, no?
Okay. Yeah, Dr. Kaushik. Then your first localization is muscle, no? Okay.
Yes, sir.
Okay. Which muscle you are meaning about? You're thinking about polymyositis or some, what muscle disease you are considering?
Oh, inflammatory myopathy, sir.
Okay.
Immune-mediated.
Then first let us take the pain. In muscle diseases, where the pain will be maximum, will it be suppose a patient has weakness of gluteal muscles and thigh muscles, where do you expect the pain to be?
Over the muscles.
Yeah, over the muscles, no? Here the pain was not over the muscles.
Yes, sir.
Okay. Then between the most striking finding in the examination, see, neurology, only the person who examines the case gets the real feel of the case. You may not have examined, so you don't get the real feel. The real feel was that the patient had severe weakness with hip abductors and extensors. More on the right side. Hip abductors were severely weak, means he could not lift against gravity also. Hip extensors were also weak. Hip flexion and adduction were only grade 4+ or very subtle weakness. So the brunt of the problem was in the hip abductors and extensors. Is that a common pattern for muscle disease? Kaushik?
Less likely, sir. Yes, sir.
This pattern of weakness, now suppose hip abductors and extensors are very severely weak. Flexors, adductors are not weak. That is, I think it's not very favorable for a muscle disease. Then the quadriceps was just mildly weak, but there was wasting over that muscle, and that reflects right quadriceps. Only right quadriceps was slightly weak, I think. Left was nearly normal. Right quadriceps with slight weakness, there was wasting, and the reflex became sluggish. Is that a point favoring muscle disease?
It's against muscles.
Yeah, because there's minimal weakness itself, a patient is having wasting, and the reflex also has become sluggish. So would you like to consider any other localization other than muscle?
Wasting being more severe than the weakness, sir.
Wasting also is only subtle. Not very, if you saw the video, the first frame, you could see that the right quadriceps was mildly wasted. Is there any other localization which you would like to consider?
Plexopathy, sir. Given diabetes history, possible plexus involvement.
What part of plexus then? Which part of plexus?
So thigh wasting, upper lumbar plexus.
No, hip abductors are supplied by which are mediated by which?
Lumbosacral trunk, sir. Hip abduction weakness will be explained lumbosacral trunk involvement.
Yeah, which are the muscles that produce hip abduction?
Gluteus medius and gluteus minimus.
Which is a nerve supplying that?
Superior gluteal nerve.
Okay. Hip extension is brought about by which muscle?
Gluteus maximus, sir.
Okay. Which is a nerve supplying that?
Inferior gluteal nerve.
Okay. Then, so suppose we think it is superior gluteal nerve and inferior gluteal nerves on both sides. One of the points you were telling against plexus where there was no sensory involvement, no?
Yes, sir.
Yeah. Is what part of skin is supplied by these nerves? Superior gluteal nerve, inferior gluteal nerve. What part of the skin is supplied by superior and inferior gluteal nerves? Kaushik, you are there.
The gluteal region, sir.
No. Do you know what? Can you put your video on?
Yes, sir. Yes, fine.
Yeah. What is the sensory innervation of the gluteal region? Can you tell that?
Sir, perineal region is supplied by S3 to S4 radicals.
Not radicals. We are talking about the nerves. It's obviously not a radiculopathy. You clearly told hip abduction extension is severely weak. Distally, there is no weakness. So we are not considering radiculopathy. We are very less likely. Regarding plexus, what is the cutaneous innervation of the gluteal region? Yeah, this is a very not at all a standard question for bedside practice. I know the gluteal region, the inferior part, is supplied by posterior cutaneous nerve of thigh and lateral cutaneous nerve of thigh. The upper part, lateral part, is supplied by iliohypogastric and iliohypogastric, and the medial part is by cutaneous nerves from L1, L2, L3, S1, S2, S3 also. So superior gluteal nerve and inferior gluteal nerve, no? These do not have a cutaneous innervation.
Purely motor.
So if these are purely motor nerves, so if these nerves are involved to even to a severe degree, you will not get any cutaneous sensory loss. Okay. So suppose we think this is superior and inferior gluteal nerves are involved bilaterally. How do we explain that mild weakness of quadriceps and mild weakness of knee flexion? How can this be explained? Okay, I'll tell. Kaushik.
Yes,
Yeah. Yeah, in my opinion, superior and inferior gluteal nerves are involved to a severe degree. The femoral nerve is involved to a lesser degree. That is why the quadriceps is also mildly weak. Knee jerk also has become sluggish. Okay. And how can knee flexion weakness alone be explained with preserved angle jerk and preserved plantar flexion? No weakness there, no reflex loss there. Is it likely? I think it's less likely, but still, in a plexopathy, even if you take the sciatic nerve has three parts: common peroneal division, tibial division, and there is probably a fascicle in sciatic nerve which supplies the hamstrings. Probably the fascicle of sciatic nerve supplying the hamstrings alone is affected. So this looks like a very odd localization, isn't it?
Yes.
But whenever we go for localization, especially when it's not clear cut, you have to take which is the major muscle weakness. The major weakness is for hip abduction and extension. Okay.
Yes.
And coupled with the pain in the lumbar region, the loin region, plexus involvement looks more likely with the superior gluteal nerve involvement, inferior gluteal nerve involvement, and very minimal involvement of right femoral nerve and bilateral sciatic nerve. Both are very minimal involvement. Superior inferior gluteal nerves alone affected is more likely. And what favors a plexopathy is also this quadriceps wasting and the right knee jerk being slightly sluggish. That is a very common finding in diabetic hypertrophy. Everyone knows that. So I think if this case is given to 5 neurologists will have 5 different opinions. I know. Now, the admitting consultant thought it was some unusual pattern of muscle weakness. The resident who presented this, I thought they told this was some radiculopathy or CADP sort of thing. I somehow felt it was plexopathy affecting superior inferior gluteal nerves bilaterally. Kaushik.
Yes, sir.
You could be right also. You could be right. It could be a muscle disease also. But I personally think it is multiple nerve involvement. Superior gluteal nerve, inferior gluteal nerve, partial involvement of femoral nerve, and partial involvement of sciatic nerve. Now, how can we prove or disprove this case? How to go about this case? Do you have any doubts on localization? You ask.
No, sir.
If you have doubt, you ask.
No, sir. No, sir.
Natural doubts you should have is why is if sciatic nerve is involved, why is only knee flexion weak? Why is not? Why aren't the plantar flexion being weak? And why is in the ankle jerk absent? That is difficult to explain, but that shows that this is a fascicular vulnerability within the nerve itself, and that also shows that this likely be a medical disease. Say surgical compressive lesions or traumatic lesions will produce full affection of that nerve. So some inflammatory disorder affecting one nerve, only one fascicle may be affected. Okay.
Yes, sir.
Overall, I thought it was a plexopathy. You thought it was a muscle disease. Anyway, neurology, nobody can be very sure. So now, how can we prove or disprove? You tell. Then we'll see that.
Nerve conduction studies are next.
Okay, we have done that. What more do you want?
EMG.
Okay, we have done that.
MRI, the lumbosacral plexus.
Before that, inflammatory muscle disease. What are the other?
CK, creatine kinase levels. Sir.
Okay, we'll do all that and see what comes out of it. But this nerve conduction study, MRI, CSF, CPK, and all of the EMG was not done that time because I think this case was seen in January 2021. That time our EMG lab was closed because of this COVID problem. Other things we'll give you. Then you tell an opinion, huh? Kaushik?
Yes.
Okay, then Ajay, we'll start screen sharing.
So sir, actually Kaushik, don't worry because almost all the residents across the country have suffered a huge academic loss because of Corona. Because these guys worked for more than 1.5 years only in the Corona ward.
Yeah,
all my residents for the past 1.5 hours. So they really require, I was telling them, really require quite a lot of catch up to do in this year. And all these teachings are going to be invaluable. Don't feel, be relaxed, Kaushik, and then go ahead.
Yes.
Okay.
Yes, sir. Yes. Yes, sir. Yes, sir.
Coming to the investigations, regarding the routine blood investigations, hemoglobin total count, platelet count, and ESR was normal. RBS was 290. LFT and RFT was normal. Creatine phosphokinase was normal, 143, and TSH was 2.03. Then we went for a vasculitic workup. ANA was negative. ANA profile was negative. C-ANCA, P-ANCA negative, and serum AC was negative. Then coming to the nerve conduction study. This is the nerve conduction study of the patient. Here we can see there is this is a motor conduction study. We can see there is reduced amplitude in deep peroneal, EDB bilaterally. Then tibial also there is reduced amplitude and velocity also decreased. It was 26 and 32. Then sensory study, left saphenous amplitude was decreased. It was 2.1 compared to 7.5 on right side. Rest of the snap was normal. Then we went for CSO study. Total cells was 2. Then protein was 52. Sugar was 90 and AD was 2. Then we went for MRI lumbar spine. MRI showed mild disc bulge at L4, L5, and L5S1 level, but there is no significant root compression. And the whole spine screening was normal, cervical and dorsal. Then this is the MRI of plexus. So here we can see this is the gluteus maximus and this is gluteus medius. And there is mild atrophy of gluteus medius and maximus. And this is the piriformis muscle. So we can compare the intensity of MRI intensity of these two muscles. So it is hypointense in case of piriformis, while in gluteus medius and minus it is hyperintense. So there is a bilateral hyperintensity in gluteus medius and maximus. So fat saturated T2. Here also we can see hyperintensity of bilateral gluteus medius and maximus. So MRI report was there is mild disc bulge at L4, L5 level with no significant root compression. Then mild atrophy of bilateral gluteal muscles. Then hyperintense signals noted in bilateral gluteus medius and left obturator externus. And these represent post-denervation changes. And there is hyperintense signals in left ischial tuberosity and hamstring tendon. And the urinary bladder wall thickening and trabeculation was there, and diverticulum within the neck from lateral wall of the urinary bladder.
Kaushik.
Yes, sir.
Yeah, now these are the investigations. What would you think now?
So there is in the NCS there was involvement of the deep peroneal nerve and the tibial nerve, along with a reduction in the amplitude of saphenous nerves. So there is possibly a sciatic nerve is involved. Along with that, we have involvement of the femoral nerve also. The saphenous branch is a branch of femoral nerve, so possibly femoral is also involved. MRI predominant involvement of bilateral hip abductors and extensors are seen. Hamstrings, gluteus medius and maximus.
So what is your conclusion from all this?
Denervation changes are seen, sir. Possibly, yes, sir. They are less likely to be muscle, more likely to be plexus. Sir.
Okay, in my opinion, these findings are all inconclusive. Gluteus medius and minimus are involved, that we can say, and compressive radiculopathy may not be there. Otherwise, I don't think these investigations are very conclusive. I cannot rely on these investigations. I would rather rely on the clinical picture. So now, is there any other way to sort this out? What is another investigation can you suggest which can sort out this issue? You may not know. I'll tell you, Kaushik.
Yes, sir.
Yeah, one most important investigation which can solve most of the neurology problems is meticulous follow-up. Treatment and follow-up. You can see the response to the treatment and how the patient behaves, and you can solve almost all issues. Another invaluable investigation is review of the literature by the resident. Both these investigations are cost-free to the patient. These investigations will solve almost all neurological issues. So from investigations, I am not sure whether
wonderful.
Yeah.
Wonderful.
Yeah, thank you, sir. So now we'll see the next investigation is follow-up of the patient. We'll see what we do to the patient and what happened to the patient. Okay, Ajay.
Okay, sir. Then considering the possibility of lumbosacral plexopathy, we gave the patient injection lethal prednisone, monthly pulse, and advanced diabetic control. So 4 months later, that is during the course of treatment, he developed right-sided foot drop with numbness or dorsum of the right foot and right lateral leg, lower part. At that time, angle dorsiflexion was grade 2, plantar flexion was normal, inversion was normal, and eversion was weak. But the proximal weakness was improving. This is a video of that patient. Here the hip abduction is normal now. So this is the nerve conduction study of the patient done on May 2021. Here we can see in right deep peroneal tibialis anterior the sigma was 1.91 compared to 7.6 on left side. So patient had foot drop at that time, and sensory snap bilateral bilateral superficial peroneal was not recorded. Previously it was normal.
Ajay, you continue.
So next patient came to us on August 2021. So that is 1 month after completing the 6 monthly pulses of medial prednisone. His proximal weakness has improved, but now he developed pain over the anterior aspect of right thigh for 1 week with allodynia and nocturnal worsening of pain. This is the new video. Now hip abduction is normal. Now he has weakness in right hip adductus. Previously it was normal. Hip extension is also normal bilaterally now. Knee extension is also weak now. Previously it was 4 plus, now it is grade 4.
Okay, Ajay, I think you can summarize that. Video is not very good. It's broken.
Okay.
Okay, knee jerk. Let us see. Knee jerk. Let us see that. Okay.
Regarding the knee jerk, left knee jerk was normal. Previously, right knee jerk was sluggish. Now it is absent. This is regarding the gait of the patient. Previously, he had waddling gait. Now it has improved. Now there is a high stepping gait because of foot drop.
Okay, Ajay, you can stop now.
There's a video.
So comparing this, patient was first seen in January 2021 and last seen in August 2021. So in January 2021, patient had predominant weakness of hip extension and hip abduction. So hip extension was grade 3 only bilaterally. Hip abduction was grade 2 on right and grade 3 on left. And there is a mild hip flexion weakness. Now in August 2021, hip flexion, extension and abduction becomes normal. Now he is having weakness only on right hip adduction. Then in January 2021, knee flexion was slightly weak on right side. It was grade 4 and the knee extension was grade 4 plus bilaterally. Now in August 2021, knee flexion is normal now, but the knee extension becomes grade 4 on right side and left side it becomes normal. Then regarding angle dorsiflexion and eversion, it was normal on January 2021. Now in August, it is grade 4 and eversion was weak. And regarding the reflexes, knee jerk was sluggish on right side on January and in August, it was absent. An angle jar was normally elicitable in January. Now it is bilaterally absent.
Okay, Kaushik. What do you think about the follow-up? Kaushik?
Yes, sir.
Yeah, after 3 months, the patient developed a foot drop. Due to what do you think it was?
The
Can you-
sensory loss over the sensory
Yeah.
loss is over the
Yeah. Yes, tell.
sensory loss over the dorsum and the lateral part of the right leg with eversion weakness. Possibly it's a common peroneal nerve involvement, sir.
Yeah, can you tell 5 localizations for unilateral foot drop?
So it could be deep peroneal nerve, common peroneal nerve,
Okay.
a sciatic nerve,
Common peroneal nerve, sciatic nerve.
lumbosacral plexopathy,
Okay, that is part of lumbar plexus. Sciatic nerve, that is part of sacral plexus. Then that's very
Cortex.
useful thing to, a very useful point to keep in mind while practicing. When we see a patient with foot drop, there are 5 localizations. One is peroneal neuropathy, other one is sciatic neuropathy, third one is L5 radiculopathy. And without sensory loss, if a patient presents with foot drop and wasting, what other diagnosis you would consider? Anterior Honsel disease also. Yes, some MND is present as foot drop. It is called pseudopolyneuritic.
With your permission, I just wanted to. I always ask them to do the medial hamstring reflex should be included in the deep tendon reflexes because it has got a definitive localizing value at that. So,
Okay.
Ajay, I would always request you to do a medial hamstring reflex in such cases where
Okay,
it has definitive localizing value. You should not miss a deep tendon reflex which has localizing value.
Okay,
I
sir.
thought you should include in your armamentarium because it's a good reflex.
Okay, sir.
Okay, L5 radiculopathy, anterior Honsel, and then it is pyramidal lesion. You said cortical lesion. Okay.
yes, sir.
How would you differentiate between all this?
So peroneal neuropathy will have inversion weakness will not be there, sir.
Yeah, correct. There'll be weakness of what?
Dorsiflexion and eversion will be weak, sir.
Dorsiflexion and?
Eversion in a common
Yeah.
peroneal nerve.
Yeah, okay.
Sciatic nerve will cause weakness of all muscles below the knee. Knee flexion, except knee extension. Knee flexion, all movements of the ankle will be lost.
Yeah, but most of sciatic neuropathies will have predominant involvement of peroneal
Common
nerve.
peroneal. Yes, sir. Common peroneal. Yes.
Okay. EMG wise, how can you differentiate between these? Sciatic neuropathy, what is the muscle which tells that the peroneal neuropathy is above the
Short head of biceps.
Short of the biceps
Yeah.
femoris.
That will
means
differentiate
that,
between that is the only muscle which is supplied by the common peroneal division of the sciatic nerve at the
Very
level of.
very good, very good. Okay. Then how do you differentiate L5 radiculopathy from peroneal neuropathy?
So L5 will cause inversion weakness along with dorsiflexion weakness, sir.
Yeah, very good, correct. Eversion is supplied by which root?
S1, sir.
Yeah, correct. Very good. L5 is inversion, eversion is S1, correct. Okay. Then with MND, there will be no sensory, no pain. There will only be wasting. Cortical, how will you differentiate from L5 radiculopathy? Suppose acute stroke.
Human signs, upper motor neuron signs will be there. Spasticity, extensor plantar.
Yeah, extensor plantar will be there. Then reflexes may be brisk. Then what about weakness pattern?
Predominant pyramidal weakness will be there, sir. Eversion will be weaker compared to eversion will be weaker compared to inversion. And
That is a routine pyramidal lesion. If it is a cortical foot area lesion, all will be weak. Inversion and eversion will be weak. Ankle dorsiflexion and EH will be weak, but plantar will be upgoing. That is the point.
Yes, sir.
Okay. Okay. So second visit, he had features of a peroneal neuropathy.
Yes, sir.
Yeah. So the inferior and superior gluteal neuropathy parts had improved actually. And waddling gait had disappeared and he developed a foot drop gait, high stepping gait. Okay. So what do you conclude from that?
Multiple nerves are getting involved, sir.
Yeah, yes.
Migrating.
What is the difference between a foot drop gait and a stamping gait? High stepping gait versus stamping gait.
So foot drop gait, patient will lift the foot high, but the toe will land first. In a high stepping gait because of posterior column or large fiber sensory loss.
No, high stepping gait occurs due to what?
Sorry, sensory large fiber sensory loss or posterior column.
No. High stepping gait is a term for foot drop.
Okay.
Posterior column.
Proprioceptive
loss produces stamping gait. There, what part of foot strikes first?
The heel, sir. There will be double tap. First the heel will strike, then the toe will strike.
Okay, that is correct. Okay. In pyramidal weakness, there will also be dragging of the foot, whereas in ordinary peroneal neuropathy, there will be high stepping. In pyramidal, it will be dragging. The forefoot will be dragging on the ground. Okay. And the third presentation, he developed weakness of features suggestive of right upper lumbar plexopathy, pain over the anterior thigh, and weakness of adductors as well as quadriceps. Adductors are supplied by which nerve?
Obturator nerve, sir.
Okay, correct. Correct. Okay. So what do you think overall? Overall, what do you think is the diagnosis?
Sir, predominantly multiple nerves are getting involved in a neuropathic pattern.
Multiple nerves are getting involved. Mononeuritis multiplex involving both lower limbs. So most probably it is at lumbosacral plexus only. That is what we thought. I think on follow-up, I think the diagnosis becomes very clear because some nerves have improved, other nerves have come up. Do you have any other diagnosis which you can consider? Now, this diabetic plexopathy itself will be a microvasculitis involving multiple nerves. So, suppose you were to do an EMG, we did an EMG. EMG, how will you differentiate between a plexopathy and versus a radiculopathy on electrophysiology? Tell 2 points.
Denervation changes will be seen on in a radicular pattern, sir. Same, the muscles.
Okay, but if multiple nerves are involved, no, there will be denervation everywhere. Tell two points in electrophysiology which can differentiate between plexopathy and radiculopathy. One is that snaps should be absent in plexopathy, in nerve involvement. Radiculopathy does not produce loss of snaps. Second one is only paraspinal EMG which will be affected in radiculopathy.
It will be normal in plexopathy.
Those are the only two differences. Okay. So we actually presented this case only because we thought it was interesting for localization. There is nothing very special or exotic about this case. Okay. Oh, Ajay, can you share screen?
So in January 2021, our diagnosis was bilateral lumbosacral plexopathy, predominantly affecting superior and inferior gluteal nerve of diabetic etiology. In August 2021, is a bilateral diabetic lumbosacral plexopathy with diabetic neuropathy. Mononeuritis multiplex. In a few words regarding diabetic radicular plexus neuropathy, just Bruns, a German neuropathologist, first described the syndrome. And Garland coined the term diabetic amyotrophy in 1950s, and it is usually characterized by diffuse pain, weakness, and areflexia. Typically affects the lower limb and is asymmetric. And it is rare and affects fewer than 1% of patients with diabetes. Usually begins with unilateral pain in the thigh or buttocks, typically spreading to other regions of the same leg and then to the opposite leg. And pain is usually followed a few weeks later by weakness, and the weight loss is characteristic. By the time the patient seeks medical attention, the symptoms and signs may be more symmetric. So the differential diagnosis include compressive or infiltrative lesions, then iatrogenic like post-radiotherapy, then vasculitis, diabetes, etc. So neuropathology is mainly ischemic injury and microvasculitis. Autonomic and sensory nerves are also involved. So management, pain control, mainly opiates may be needed at the onset, then amitriptyline, gabapentin, etc. Then we have to consider a short course of steroids if the pain remains unremitting. Usually oral or intravenous methylprednisolone 500 milligram per day for 2 days, repeated every 2 weeks for 2 to 3 months. Then physiotherapy, and maintaining good diabetic control. And there is no evidence that switching to insulin is helpful. Prognosis, the time course of the condition is prolonged. It usually begins in one leg. It commonly spreads to other leg within a weeks or month. It can worsen in a slowly progressive or stepwise manner up to 18 months. Eventually, the process stabilizes and gradually improves. Recovery may take many months, and patients should be informed that some degree of permanent weakness may persist.
Okay, stop screen share.
Thank you.
Okay, sir. We are done.
Thank you. Thank you for a wonderful case and a wonderful case decision, Dr. Jacob, on such a short notice. And I tell you, every resident who's joined here, the beautiful localization of the various causes of foot drop and how the case evolved over months, each time with differing patterns, reiterates that the follow-up and clinical examination, very, very methodical clinical examination is how essential it is. And Sir has also added that how invaluable that literature search. These, if each resident has this take-home message, I am very happy. This is the, in fact, Sir, I am a very big fan of Dr. Jacob, sir. He is one of the top clinical neurologists in the country, who is very unassuming and very modest. I want the entire country to know that the kind of cases which he has posted on YouTube for all the clinical dissections, it's lovely to watch, sir. You can enjoy them, and the various discussions he used to put challenges of various cases. which I used to, sometimes it is beyond my head, but anyhow, I always enjoyed the findings, and congratulations to you, Jacob George, for
Thank
your
you, sir.
wonderful presentation.
Thank you. Sir.
Thank you. Thank you. And I hand over the mic to Professor Sudhir Shah for concluding remarks.
I perfectly agree with Dr. Lakshmi in saying great words of appreciation for Dr. Jacob George. The way he clinically dissected the case from the beginning, and why he was persisting on plexopathy, the way he discussed the localization, and why this kind of foot drop is due to plexopathy, what are the electrophysiological findings. All these things are wonderful clinical pulse for any budding neurologist, and I'm sure students must have learned a lot from this beautiful small pulse. And this is how this is a very common clinical area where we come across patient with foot drop and patient with proximal weakness, asymmetric weakness. This is day-to-day neurology in which we see in busy OPD. And if we follow this pulse, I'm sure we relate to the diagnosis from the beginning. So it will avoid unnecessary investigation. And most importantly, as I said, the most important investigation is follow-up of the patient, review by the neurologist or his residents, and all those are blessed with medical schools, or those are attached. They're a wonderful gift that there are a lot of people to solve one case. So that is the beauty of a medical college or school. So once again, I'm closing my remarks with saluting all the teachers who are here, who have poured their hearts in training the neurology students, putting aside everything, all personal interests. They are doing such a great service to the nation. Why only India? All across the globe, all neurologists, all cardiologists, all medical teachers, and other fraternity teachers. We salute them all, and we hope that the flame of knowledge would percolate into the patient well-being through, from teacher to students. And I really want to thank all teachers once again. Thanks to Dr. Jacob, thanks to Lakshmi, my close friend, all the students who have done their best today, and all the attendees once again. And I must not forget again Mr. Chadda and his team for continuous, unwavering support for this medical endeavor. Thank you very much.
Thank you, sir. And thanks. Good evening to all. And today it is auspicious day as we are celebrating the Teachers' Day episode of Secrets of Neurology. And my sincere thanks to both the directors and both the teachers, Lakshmi Narasimhan sir, as well as Dr. Sudhir Shah sir, for this beautiful Secrets of Neurology web series. It turned out to be very successful, as today there was 250 plus delegates who makes these episodes memorable. And I, Arun Chadda, Senior General Manager, on behalf of Intas Pharmaceutical, would like to propose a hearty word of thanks to all the honorable delegates who blessed us with their presence, and its audience like you that makes the presentation awesome. Thank you very much for your unwavering attention throughout this presentation. First of all, I would like to congratulate and thank our Honorable Course Director, Dr. Sudhir Shah sir, and Dr. Lakshmi Narasimhan sir for this longest web series, which they have designed in such a fantastic way on this neurological case studies, which will be very helpful to all the DM and DNB students. And I would like to thank our young neurologist, Dr. Ajay Radhakrishnan and Dr. Kaushik, for presenting the excellent and unique case. Further to this, I would like to thank the Government Medical College Kottayam Neurological Team and Dr. Jacob George, sir, has given their excellent inputs and expert comments for such a unique case, fabulous presentation. The entire presentation will be extremely helpful and informative to all the present participants. Once again, thank you for your gracious presence, and it's been a pleasure being with all of you today. Thank you for your patience, and I wish you all a very good night now, with a promise that on 24th September 21st, we'll meet with yet another most awaited next session of Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you, sir. Thank you very much.
Thank you, sir.